Hello, everyone. My name is Dr. Sadiq Bhayani. I'm a consultant staff physician in pain management at Cleveland Clinic in Abu Dhabi. And I hope you all are enjoying the conference. I would like to thank the Pain Association Singapore, the scientific committee organizers, uh, to invite me for this conference. It's an honor and a privilege to be on this platform. Uh, I've been asked to talk about regenerative medicine for pain management, and I've been given like 25 minutes. So hopefully, in over a period of next 25 minutes, I'll give you a good run through about what are the applications of regenerative medicine in pain management. So this is Cleveland Clinic Abu Dhabi. So this is the place where I work. It's an iconic institution in Abu Dhabi in the field of medicine as well as pain management, because we are the tertiary referral center, and we get referral from all over the Gulf region and also from various parts of the world. So this is the iconic building. If you ever visit Abu Dhabi, do contact me if you want to come and have a look around our service. So disclosures, nothing related to this talk. I do have other disclosures. Say I'm a consultant in pain management at Cleveland Clinic in Abu Dhabi. I was in e-pain clinical lead for Faculty of Pain Medicine, Royal College of Anaesthetists. I'm a founder of Leicester Pain Education, founder of Pain Talks and Pain Fluids. So this is a Leicester Pain Education that we established back in 2015. Like Netflix, I worked on this video platform called PainFlix, and it's available on this website called blockit.club. And Pain Talks Education is a free educational platform where I invite various speakers nationally and internationally, well-renowned speakers in the field, and they come and give us short talks on various clinical topics. So let's get into our actual presentation. You must have come across headlines like this: PRP help Cove to kind of play a game so it can help you. And majority of the application of PRP is actually in the sports medicine world. So going back to the basics, what is regenerative medicine? The application of orthobiologics to the damaged tissue to stimulate natural healing process, encourage growth of healthy tissue, or to replace the biologically active mediators. So it's a kind of a very comprehensive medicine, or the other way you could say regenerative medicine is a process of replacing or regenerating human cells, tissues, or organs to restore or reestablish the normal function. So basically it's using the cells to replace the cells or to replace the biologically active mediators. Now, regenerative medicine for pain management, the approach became very popular over a period of last 5 to 10 years. It builds off the theory of prolotherapy. It uses patients' own cells or growth factors. And when we're talking about PRP, we're actually talking about the growth factors to repair the damaged musculoskeletal tissue. Treatment should restore the normal function and also also give rise to pain relief. Unless the area is re-injured, the treatment should be permanent. Now, there are two basic treatments: PRP and stem cell therapy. Now, this is the kind of full kind of comprehensive regenerative medicine options that you have. You have options of cellular therapy, you have options of cell therapy enhancers, scaffolds, delivery systems, gene therapy, and biologics. Now, I'm actually going to talk about biologics, but mostly about platelet-rich plasma. So what's the history of PRP? The use of PRP was first described in 1972. Large volume autotransfusion equipment was needed. You needed to take 500 ml of blood. It was done in operating room. It was a quite cumbersome process. So we had a very limited adoption of the procedure because of the lack of proof of sources. It wasn't cost effective. It was equipment and operator dependent. But the therapy survived its own clinical merits. So it was doing something, and it carried on making advances in the field. And the first prolotherapy was described in 1938. So about 40 years later, or 38 years later, that we realized that PRP is something that does work like prolotherapy. So moving on to blood cell functions. Now, what is PRP? So when we talk about the full blood, whole blood, we have red blood cells. The function of that is oxygen and carbon dioxide transport. White cells, they have immune defense function, but it's a platelet. So in addition to the coagulation of the blood, it also has growth factors which leads to wound healing. And in PRP, it's, as the word stands, it's platelet rich plasma. There is also platelet poor plasma, and we'll talk about that later on in the talk. But platelet rich plasma has a plasma, platelet concentrate, and growth factors. And this is what you do. You take the blood, you basically spin it down, and then you have an area where you can actually collect the plasma. You can have a platelet poor plasma, and you can actually have an area where the platelets are very much concentrated. So from 60 mLs of blood, if you centrifuge it down to 6 mLs, you increase the platelet concentration from 650%. Now, remember, every kit is different. You will have the kits which may not be achieving that percentage of platelet count, but there are lots of kits available on the market, and if you use a cell counter, you can decide which kit is offering the maximum yield. It's called yield of the platelets. Now, why concentrate platelets? Platelets are the source of growth factors. We have alpha granules and dense granules. So in terms of the growth factors, it's the alpha granules that we focus on. Then you have platelet growth factor, transforming growth factor, vascular endothelial growth factor, connective tissue growth factor, epidermal growth factor. So if you see, all these growth factors have a significant role to play in the regeneration of the tissue. Now, what are the potential benefits? When you talk about platelet-rich plasma versus steroids, platelet-rich plasma is autologous. It results in no immunologic response. There are no issues of allergy or anaphylaxis. It provides full array of naturally occurring growth factors to initiate both soft tissue and bone healing. And it enhances angiogenesis. It increases the collagen content. So there are multiple advantages of platelet-rich plasma. Now, when we talk about platelet-rich plasma, people also kind of, say, okay, is this similar to stem cells? No, it's not. Platelet-rich plasma is basically focusing on platelets. So PRP is derived, provides growth factors, stimulate angiogenesis. On contrary, stem cells are the cells that are actually harvested from the bone marrow, and they provide a source of cells to repair the damaged tissue. So PRP provides mostly the growth factors, and stem cells are basically the cell way of regenerating the tissue. So now, there are various kits available on the market. I'm just showing you the one I'm familiar with. This is a double syringe kit where you take the blood and you have a centrifuge and you centrifuge it down. So you have to aspirate the blood through wide bore needle. It's very important to use a butterfly or a wide bore needle about 18 gauge, so you don't give rise to hemolysis. Then after that, you spin it down to 1500 rotations per minute for 5 minutes. It's a closed system. Then you pull the syringe, the inner one, and then that you got your platelet-rich plasma ready for injection. So these are just showing you the steps: centrifugation, plasma with platelets, and then you have the platelet-rich plasma, and then the concentration of platelet-rich plasma has gone up 80% more platelets. So things to remember: prime the syringe, depends on what kit you're using, but usually majority of the syringes that are available on the market, especially the double syringe technique, you have to prime the syringe. You have to you have to withdraw the recommended blood. Use a butterfly needle. The patient should be advised to stay well hydrated at least for a week up until their injection. No non-steroidals. This is a very important thing. So they shouldn't be taking any non-steroids for at least 2 weeks post-treatment and 1 week prior to because if they are on aspirin, you need to ask them to stop aspirin in order to reverse the platelet function. The other important bit to keep in mind is also use of steroids. If somebody has had a recent steroid injection, then I will not do a PRP treatment for at least 1 month. Okay, so, and we don't use local anesthesia mixed with platelet-rich plasma, because you will actually negate the effect of platelet-rich plasma because of change in pH. So you can use local anesthetic in skin and subcutaneous tissue, but the actual area like joint, you will not inject local anesthetic in the joint. So practical tips, you can use 25 gauge or larger needle into the injury site. I think ultrasound revolutionized the field, because you are now putting an active substance very confidently in the area where it needs to go. It's not only just serves as diagnostic, but it also serves us to deliver the medication in the right area. Inject about 1 ml of PRP in the area of tear, frayed ligament, or injury site. So we're talking about ligaments or tendon tears. Majority of times people would fenestrate the area, which is called peppering of the area. So you will actually use dry needle in and out, and you actually will create a lot of fenestrations, and then you will douse that area with platelet-rich plasma. Have patient rest 15 minutes before getting up, and you will have to give them a very proper instructions afterwards. So the patient will experience some pain and soreness for 2 to 5 days. So you have to tell them this is different than steroid injections. After steroids, patients don't actually get that much of flare-up. Very rarely they get steroid flare-up. But with PRP treatment, they will feel sore for minimum 5 days. And then, you need to take them to take analgesics in the form of regular paracetamol, use ice packs. So those instructions are very important. And also loading of the joint and the post-procedure rehabilitation process carries a maximum importance here. Just putting platelet-rich plasma is not going to yield you any benefit unless you give them all these instructions. So apply ice compression, take analgesics for 48 to 72 hours, minimize the lower activity of inject area for 48 hours, followed by guided activity levels. So don't load the joint straight away. It's a gradual loading. Avoid excessive strain, weight training for 3 to 6 weeks. So I usually tell the patients, if I do PRP for 2 months, don't do any weight training, because you really want the joint to settle, the PRP to do its job. Otherwise, if you start to load the joint again, the injury can be worsened. So in general, the immobilization is not recommended. You do ask the patient to kind of walk, do their day-to-day activity. It's just a loading of the joint. That's not recommended. Begin physical therapy as indicated, typically 2 weeks after the injection. Okay. Now, what are the contraindications? What are the patients where you won't do PRP? If they have a low platelet, if they have a low hemoglobin, if they're hemodynamically unstable, if they have dysfunctional platelets, so hemophilics, or if they have a kind of clotting issues, if they have renal failure. Renal failure does affect platelets, so you really want to choose your patients right. If they've had a corticosteroid treatment, as I said, majority of people recommend 2 weeks. I recommend 4 weeks, so I wait for a month. If they've had steroids by mouth as well, I will wait for a month. If they have concurrent illness or septicemia, you won't be doing PRP treatment, as well as cancer. If they have a hemopoietic or bone cancer, you won't do PRP on those patients. And also the infection at the site, cellulitis, we won't be doing PRP for those patients. Now, moving on to a more practical part about indications. Now, every part of the body has had platelet-rich plasma being used. You can use it in shoulder, cervical region, lumbar spine, sacroiliac joint, hip, knee, ankle, elbow. And I'll talk you about the evidence of the commonly performed PRP treatment. So these are all the indications. So there are acute indications and there are chronic indications. You can use it for Achilles tendon injuries and acute injuries, or rotator cuff injuries, especially the basketball players. They usually have rotator cuff injuries, or tennis players, and they usually get PRP injected in the acute injury phase. You can use it for ligamental injuries as well, medial collateral ligament or ankle ligaments or ACL tears. Chronic, from our point of view, patients with grade 1 or grade 2 osteoarthritis, tendinopathies, which are chronic conditions like Achilles tendon tendinopathy, tennis elbow, golfer's elbow, patellar tendinitis, and then we have plantar fasciitis. So these are the joint-related areas. In terms of spine, yes, people have used platelets in discs. They've used platelets for sacroiliac joint and facet joints. So what's the evidence for PRP? Unfortunately, there are areas where there's a lot of evidence, but there are areas where there is a very minimal or sketchy evidence, and it's all down to basic science, the clinical research, and there are very, very there is a gray area, as well as there are many unknowns. Now, when you talk about basic sciences, the basic science is still evolving. We have a lack of clear understanding of stem cells' role, biology, and interference. So it's evolving. We are getting quite a lot of data, what cells are doing what is the function of the alpha granules, what is the function of the growth factors. Now, when we talk about problems in the clinical research, we have lack of universal protocol. If you ask people how many times you do PRP treatment, do you do 1 time, 2 times, 3 times? Everybody will have a different take on it. There's a lack of universal technique. Few people will use kind of platelet poor plasma. Few people will use a platelet rich plasma. Also, the volume differs. And there's a lack of universal patient selection criteria. So when you have a lack of all these areas, it becomes very difficult to get a good quality clinical research. So other problems are what concentration of platelet are you using? Are you using manual system or are you using a semi-automatic system? Are you using leukocyte rich or leukocyte poor? Are you doing one injection or many injection? So there are many, many questions that are unanswered. And do we do repeat? How many times you repeat? And what's the duration between the 2 repeat injections? So lots of questions need to be answered. When you talk about osteoarthritis, how much damage is too much damage? That needs to, what is the name of the product? What is the best product? How much is the volume? What's the timing of the injection? Do we do leukocyte rich, leukocyte poor? In general, the consensus now is you would use leukocyte rich in the areas like tendons, and leukocyte poor is mostly injected in the joints. Indications for specific injuries or disc disease, what are the indications? And there's also lack of effective rehab protocol in every trial they've done. So there are many and they also had placental growth factors that was used. Now the placental growth factors have been banned by FDA in the United States. So there's a lot of kind of unanswered questions that we are waiting for. So when you talk about the platelet-rich plasma evidence, you can't be looking at just one journal. There are so many journals which actually you can look at to find the evidence. So Journal of Sports Medicine, Clinical Orthopedics and Research, then you have Journal of Bone and Joint Surgery, Knee Surgery, Sports Traumatology, Arthroscopy. Arthroscopy is another journal, and Journal of Shoulder Elbow Surgery. So a lot of journals out there, and you will find that there's a lot of papers that get published on PRP. Now, does the PRP work? Is there an evidence? And I would say it's 50-50. There are lots of studies which supports its use. There are lots of studies which actually refutes its use. So let's go through the commonly performed areas, the commonly injected areas for PRP. PRP for knee, I think it has a fantastic evidence, and evidence is much better than actually arthroscopy or knee replacement. When you talk about knee replacement, this was a study that was conducted in the United States, and it recommended if procedures were restricted to more severely affected patients, its effectiveness would rise, with practice becoming economically more attractive than its current use. So the knee replacements get done way much, and it has very minimal effect on the quality of life as per this study. Now we know that it's well supported that if somebody has a grade 3 osteoarthritis or they have mechanical issues, knee joint surgery is what is recommended. Also arthroscopy for degenerative arthritis and meniscal tears. And this study showed the panel is confident that the arthroscopic knee surgery does not, on average, result in an improvement in long-term pain or function. And if you're just doing arthroscopy in the UK, it's actually not allowed. You have to do debridement. You have to do some kind of procedure in addition to the arthroscopy. So diagnostic arthroscopies are now not funded by National Health Service, and they're not NICE recommended. So when you talk about arthroscopy and surgery, especially in the early osteoarthritis, people go for corticosteroids. Now, when you talk about corticosteroids, they are cytotoxic, and this is a very good paper talking about cytotoxicity of various drugs that are used. So from my point of view, if you are using bupivacaine, you are using a cytotoxic drug, which is much more cytotoxic as compared to lidocaine. So the least cytotoxic local anesthetic is ropivacaine. Bupivacaine is the most toxic one. The triamcinolone does have cytotoxicity. Depomedrone does have cytotoxicity, but people do use steroids very much widely. So it does reduce the volume of the cartilage if you keep using. And this is another study, effects of intra-articular triamcinolone versus saline on knee cartilage volume and pain in patients with knee osteoarthritis. So this showed that the patients who got steroids injected as compared to intra-articular saline had a significantly greater cartilage volume loss. So you always have to think, do I inject PRP or do I inject steroids? Steroids is cheap, it's available widely, that's why people have been using it. Now, they have also compared the PRP on pain and physical function in knee osteoarthritis, and they compared with all other treatment, corticosteroids, ozone, hyaluronic acid, and they found there was significant benefit at 3 months, 6 months, and 12 months. So these are all the studies, level 1 randomized controlled trials that are done in knee osteoarthritis, and I can tell you knee osteoarthritis and the use of PRP, especially grade 1, grade 2 osteoarthritis, has a significant support in terms of evidence, and I would highly recommend that. So this is the editorial. That's it. The time has come to try intra-articular platelet-rich plasma injections for your patients with symptomatic knee osteoarthritis. So these are the papers, if anybody wants to look at them. Two key papers. This was Smith 2016, showed 78% improvement in WOMAC score. So we're not just talking about the pain score, we're talking about the functional scoring. Also, Dye's 2016 paper showed PRP injection to provide significantly superior pain reduction and symptom improvement at 12 months. And the studies had decent number of patients as well. So for knee, definitely a good way to do it. For hip, on the other side, unfortunately, there is no evidence. So it's no difference at 6 months or a year. And this is a paper from International Journal of Surgery, and then they found it's better for pain reduction at 2 months, but at 6 months there's no difference. PRP for elbow. Now, elbow, you always want to try other things. So rest, stretching, counterforce brace, eccentric exercise program, physical therapy. Corticosteroid injection is being debated. It does reduce the pain and possibly will help your patients to participate in the physical therapy. But there are many studies of use of PRP for lateral epicondylitis or the tennis elbow. And these are just some of them I've quoted here. And you will see the PRP does improve the pain. It does improve the VAS scores and also improves the function. So it does have a role. And then this is a Pierboom study from 2010. PRP showed significantly better pain scores and improved the patient's scores, functional scores. So disability scores for shoulder and hand, that's the scoring system they use, and it improved in the PRP group 73% as compared to the steroid group. So there is a good evidence that you can use a PRP for lateral epicondylitis. It's safe, it's effective, and there are randomized control trials proving that. Moving on to the another level 1 study. Now here you look at this, and the reason I put this is slightly controversial, and that's why I say the research can be basically very much difficult to decide on. But this study was a level 1 study in 2013 from Alan Mishra, showed leukocyte-rich PRP group, dry needling at 6 months, 84% success rate with PRP, 68% success rate with dry needling. So sometimes dry needling itself works. So we always, but when you look at all these studies, I'm just going back, they're very much in support of PRP. So in my practice for knee, yes, PRP is a good treatment to use. For lateral epicondyle, yes, it's a good treatment to use. Hip, no, I don't think there is enough evidence to support that. In terms of gluteal tendinopathies, yes, you do have a leukocyte-rich PRP injection treatment with sustained effect at 2 years with improvement in pain and function. So that's another treatment that is useful. So if somebody has gluteus minimus or gluteus medius tendinopathy, I would go with the PRP. Talking about the rotator cuff, PRP does reduce the pain and improves the function at 6 months. And this is a study from clinical rehabilitation proving that. Achilles tendon, PRP outcomes are no better than saline. And this is a study, the meta-analysis of 4 level 1 studies published in 2018 from clinical orthopedics and research, related research. Now, what is the evidence for PRP for spine? This is the document from American Society of Interventional Pain Physicians. Do regenerative medicine therapies provide long-term relief in chronic low back pain? And this was a systematic review. It says it may be effective in managing discogenic low back pain, radicular pain, or facet joint pain, or sacroiliac joint pain with variable level of evidence. Another sort of paper published in Pain Physician about use of PRP and the ACIP guidelines. And it says it shows the evidence synthesis is summarized above. There's a level 3 evidence for intradiscal PRP. So for disc, no good evidence. And the evidence for lumbar facet, lumbar epidural sacroiliac joint is actually very poor. It's level 4. So for PRP for spine, I still find it's too early to start using that. Same thing, people have used PRP in the neck, sort of cervical disc, and they said the results are durable with successful outcome. But this study had a very small number of patients. Now, another study, use of PRP for sacroiliac joint, and it was compared with steroids, and it showed it did improve the pain significantly in the PRP group. So just one study, not that many studies. Now, there are lots of other applications of PRP. PRP for piriformis, PRP for iliopsoas tendon, ACL tears, MCL tears, and meniscal tears. Now, are there any studies? Unfortunately, it's a journal of no known studies. We don't have that many RCTs commenting on it. So I'm just 1 minute over. So in summary, there are many randomized controlled trials and strong evidence for use of PRP in osteoarthritis, level 3 evidence for disc, level 4 evidence for facet joints and sacroiliac joint. So spine, too early to recommend its use. I would definitely recommend it for the joints, also in particular knee joint as compared to hip and shoulder. So it is better than steroids, but as I said, more evidence is needed. If you guys want to connect with me, I am available on LinkedIn network. So, and that's my ID, Sadiq Bhayani. Now, I would like to take an opportunity to invite you all to Leicester at the Leicester Race Course in June. We are running an international conference. It's the third international conference on ultrasound in pain medicine, regenerative medicine, and peripheral neuromodulation. So we have a huge amount of regenerative medicine included as a part of the conference. It's recognized for 10 CME or CPD points from Royal College of Anaesthetists in the UK. We have a master faculty, Prof. Bernard Murugel. He's a well-known figure in the field of anatomy and ultrasound in regional anesthesia and pain medicine, who will be joining us. So please do come to Leicester. It's only 1 hour drive or a train from London, and quite a lot of places to see. It's a scenic place, and I would love you guys to have you with us. So thanks very much. I really appreciate, and thank you once again to the Pain Association Singapore for giving me this opportunity to present. Thanks a lot.